So it's very hard to have a discussion of women in science for more than about 2 microseconds without the issue of the two-body opportunity coming up. And we have to rethink the two-body problem and make it into a positive. One of the most well-advertised and visible cases of this was when the Berg family moved to Pittsburgh earlier this year, I believe. And so Jeremy and Wendy Berg are going to tell us about their experience being the two-body opportunity for University of Pittsburgh, and they're going to talk about the give and take of 2 careers and a family.
All right. Just while we're waiting for the slides to get started, so it's a real pleasure to be here. It's particularly delightful to be almost the only man in the room, an experience that many men would benefit from, I think. So I'm going to start off and talk a little bit about our career trajectories, and then Wendy's going to talk after that about breast cancer screening, which is, I think, what got Carla's attention when she spoke at the Women's Health Conference, to hear some of the science that this has been all about. So just to start off, this is a timeline to show that this is not a one-time event, but it's actually been a complicated set of career transitions and family transitions starting in quantitative analysis class in college when we were lab partners together. And Wendy, who was much more perceptive than I am, went home and said, I think I just met the man who I'm going to marry. Told her roommate that night. We started dating. Things were going along fine. There was an event somewhere in here where one of us, we don't need to assign fault, but we were separated for a while due to some really bad decisions. And then on July 4th in 1983, I was at a 4th of July party at a college friend's house in Boston, and the other person there was Wendy's ex-fiancée. So Wendy had been planning to get married and called off the wedding 9 days before the wedding because her father, bless him, said, do you feel about him like the way you felt about Jeremy? And she said, of course not, but that's not really relevant, is it? And I had been feeling like I had completely screwed up, and then so I went to this party and met her ex-fiancée, who said, Wendy and I have split up forever. I'm sure she's glad to hear from you, and if I'd had a cell phone, it would have come out immediately. I didn't go to see the fireworks on the Boston Common, went home and called Wendy. Visited Baltimore a couple weeks later. We were engaged fairly shortly thereafter and married just as I was finishing up my PhD. There also are other players in the system, namely, and you saw them on the first slide, Alexander, who hopefully was just sworn in, having passed the bar this morning. Corey, who you'll hear more about, and Monica, you'll hear from at the end. And they have all figured in this complicated puzzle all the way along the way. There's actually a connection with Rosalind Franklin. So when Wendy and I got back together, I had, before then, had been working on my postdoctoral plans and had a fellowship in hand to go work at the MRC lab with Aaron Klug. And Wendy was in the MD PhD program at Hopkins, and we were trying to figure out things for her to do a month at a time in England and so on, because the idea of getting married and then moving an ocean apart didn't appeal to either one of us very much. And I woke up one morning with an epiphany that there was a much simpler solution to the problem, and that is actually going to Baltimore to do a postdoc and missing this other opportunity, but it seemed like a better solution. I'd already met people there and set up a postdoctoral fellowship with Carl Pabo, who is a young assistant professor in the biophysics department at Hopkins. Was able to transfer my fellowship. So I said, would you like a postdoc? I've got my own money. And he said, sure. And it worked out incredibly well. I had also started, I come from a chemistry background where relatively short postdocs were much more common, still are, but certainly then. I'd started to apply for faculty positions, hadn't gone as far as to applying to Hopkins because of Wendy's situation there. Withdrew my application. They'd gone through their search, hadn't hired anybody, and they said, why don't you come interview? We understand you want to do a postdoc. See what happens. Went through the interview. Was certainly one of the big positives that was offered a position. One of the big positives was I had a solution to the two-career problem right off the bat, which was not to be laughed at. I was promised newly renovated space, which, of course, did not materialize. It was done 12 years later, something like that. after I moved probably twice. This was not an easy decision in the sense that the Hopkins chemistry department was good but not great, and it was the only position I'd applied for, and my mentors and so on said, you can do better than this. The quality of the graduate students there isn't what you can. And I sort of said, yeah, fine, but this is going to work for me. And on the other side, even some of the Hopkins faculty said, he's going to do a postdoc, he's going to decide to go somewhere else, we're just wasting our time, we shouldn't do this. But it worked out quite well. Meanwhile, since we'd now played the leapfrog game, I was now committed to Baltimore. Wendy finished up her medical school training, her MD PhD training, was interested in breast imaging. Hopkins was not a particularly good place for doing breast imaging. Her mentors at the leadership in the radiology department at Hopkins said, if you want to do breast imaging, you should go do a fellowship somewhere else. And Peoria is actually not a joke here, but actually that was one of the places to go train. She instead, because of my situation, stayed at Hopkins, did a internship, residency in abdominal imaging, but developed her interest in breast imaging largely on her own, but also started developing collaborations and mentors outside Hopkins, since that's where the action was in breast imaging. So after 3 years in the chemistry department, I got a very surprising phone call. My science had gone really, really well. I'd actually ended up working on zinc fingers, which had been discovered in Aaron Klug's lab while I was there. Before I was going there. And, in terms of my career, not going to his lab was the best thing that could have possibly happened to me. Because if I'd been there, I would have been on the ground floor on this problem, and it would have been Klug et al. I would have been all for the rest of my career, as opposed to being his competitor. So who knows how these things work out. Anyway, I got a phone call from the search committee from the biophysics department at Hopkins Medical School, where I'd been a postdoc, saying, did I want to be considered for the department chair? And I literally said, after dropping the phone, I said, why would I want to ruin my career at such an early stage? And I was concerned about research, which was going great, teaching, which I enjoyed, family. Alex had been born at that point. And the other department directors who I'd enjoyed working with when I was a postdoc were very persuasive. They had a very well-thought-out plan. A different one of them showed up on my office door every day for 5 days in a row, sort of saying, no, this is really a good idea, and eventually was persuaded to give it a try. As I mentioned, Alex had been born in 1986 when Wendy was had finished up her experiments for her PhD and was just writing her thesis, was done with her clinical work. So she was busily writing her thesis. One of her very clever strategies was always being incredibly busy and really working especially hard when all the kids were infants. So what they learned in the middle of the night, that the only word that worked to get anybody's attention was daddy. Very strategic decision. Anyway, Wendy's mother had come to help out when Alex was first born and stayed, the usual few weeks, and ended up staying for 12 years with sun interruptions, and actually is still living. She moved with us to Pittsburgh, so it's been now quite a long time, not always in the same house. One of the things that we discovered, this is a Chinese character, which is two women under one roof. This is the Chinese character for trouble, also translated as war. So this was not entirely without some friction, but it worked out very well. And then Corey came along in 1990. So this is Alex getting ready to go to his first day of first grade? Kindergarten. And Corey and Wendy's mom and some young guy who I don't recognize. So as I became department chair, I was now the ripe old age of 32, and there, the Hopkins Medical School was, they were actually doing a strategic plan, and one of the lines was that Hopkins was perceived as a male-dominated environment. And I literally suggested in a meeting by anybody with an IQ over 40. It was very male-dominated, very much dominated by men in their 50s or 60s with wives who were generally not professional and generally took care of all the other stuff. So it was a real interesting fit for somebody with a professional wife with young kids and so on. So we had some childcare problems early on. See the previous slide about two women under one roof. So I just had to bring Corey to work with me some days. And I delivered some paperwork. I was on a search committee for a division chief in the Department of Medicine. And I brought Corey with me in a backpack to work just to drop off some paperwork. I never saw the chair. And to my complete astonishment, like 6 weeks later, there was a retreat of department directors and spouses, and 4 different wives came up to me and said they'd heard about this. And I was like, this was not a big deal. I was really just completely puzzled that this was so noteworthy. It wasn't on my list of accomplishments for that month, was bringing my kid to work with me. But it was clearly something that the culture did not really regard it as an unusual event. This actually had longer-term ramifications. So Hopkins had been debating having on-site daycare. They did not have a daycare center. They periodically, about every 3 years, they would do surveys and say, well, come to the amazing conclusion that the demand depended on the cost, that if it were $80 a week, there was an infinite demand. If it was $700 a week, there was no demand. And the faculty were going completely crazy with this whole thing because they just kept getting studied and they kept refusing to come to a decision. So the faculty, I don't know who came up with this brilliant idea, but the faculty council voted they either had to create a center or agree not to study it for 5 years. And that's actually a very good strategy. So they created the center. This was now quite a number of years later. And Corey and I were actually invited to the invitation. He'd become the sort of poster child for the child care problem, even though he was one of, hundreds or thousands of kids, and we actually had solved our child care problems in other ways. So, but again, it was sort of this unusual reaction to being confronted with the realities of 2 careers and kids and so on. So meanwhile, back with Wendy's career, she'd been doing very well in breast imaging. The situation at Hopkins had gotten complicated for political reasons. They did have a breast imaging division, but the position was filled because of sort of internal politics and so on. There was clearly she wasn't going to be able to have a chance to do much breast imaging there. Because of now my anchoring in Baltimore, she sought out a position at the University of Maryland across town. There was a relatively new chair there who had been at Hopkins previously. She approached him, was offered the directorship of breast imaging, an assistant professor, thrived there, built the division to some degree, was promoted to full professor with tenure in 7 years, was in the process of putting together funding for the trial, one of the trials that you hear about, a prospective trial looking at ultrasound as an adjunct to mammography for breast cancer screening, and we'll come back to that in a minute. So, meanwhile, things were continuing to go well for me scientifically. I got a letter offering me a position to come back to the chemistry department at Harvard, where I had been a graduate student. Very flattering. I'd had a very good time there. Going back, meeting with faculty was a little bit surreal, to be perfectly honest. When you're a graduate student there, you don't get a whole lot of respect. Acknowledgement in the hall is sort of a pretty good thing. And, being meted and greeted and treated as a distinguished visitor was lots of fun. But the thing that I was most worried about in terms of sort of actually having to confront this decision was lunch with the graduate students, because I remembered my classmates as being very bright and very ambitious and so on. And I walked into the room, and there were 24 graduate students. They were all men, and it was like getting hit with a ton of bricks. I said, "Oh, I remember this place. It's totally socially pathological. I don't want any part of this." And we ended up spending the entire lunchtime talking about how it was impossible to recruit female graduate students because they were only 15% women, and they just, women would come there and they would say, "Graduate student is stressful enough. Why do I need to feel so strange, lonely?" And also just objectified in various ways I could go into later on. And also Wendy, even though they sort of acknowledged that we had a two-career issue, I think they certainly did not treat it as a two-career opportunity, but they made some sort of minimal arrangements for her, and she was treated as a sort of, well, if your husband gets this job, of course you'll accept whatever position we might be able to scrounge up for you sort of way. So decided not to go there. Meanwhile, back at University of Maryland, things, as I said, had been going very well. There was a new chair who was recruited, and he and Wendy really sort of struggled. I mean, his breast imaging had moved out of the hospital into an outpatient center, and he viewed the outpatient center as something that should be focused on generating revenue for the academic missions of the department, but was the only place to do breast imaging. So it was like Wendy was saying, but I really am interested in research. I have this funding lined up. I'm really interested in teaching. This is the only place to do breast imaging. Let's solve this problem. And to make a number of long stories short, it was clear it wasn't going to work out. Meanwhile, she had completed the fundraising for this multi-center trial for looking at ultrasound as an adjunct to mammography. I came home from work one day, I think, or maybe it was on the phone, and she said, well, I quit. And I said, I quit as in I'm frustrated, I can't take it anymore? And she said, no, I quit as in I gave them 3 weeks' notice. And I said, well, that's interesting. I know you always have a plan, so do you have a plan? And she was still working on it, but what she had set up was something where she was seeing patients in a private practice as a per diem employee without a contract, and then doing research without any institutional affiliation, so running this multi-center trial. And places said, you can't do that. And she sort of said, I don't see anything that says I can't do that. And then people would call up and said, I need to talk to your sponsored research office. And they would say, this is she. And then she would, the only time it wasn't Wendy, which we got IT issues occasionally got pushed my direction, but that was the entire operation for a while. And this work, as you'll hear, worked out very, very well. So back with me, meanwhile, sort of at this almost exactly at the same time, I had been approached from the search committee looking for the director of the National Institute of Medical Sciences at NIH. The first phone call, again, teamwork works well. The first phone call was somebody on the search committee, and I said, it's nothing that I'd thought of, but I certainly will take a look and so on. Another person on the search committee was Ruth Kirstein, who I'd known from postdoctoral affairs sorts of things, who had been a long-time director of NIGMS, and somebody actually, turns out later on, I have deep family connections with, but I did not know about those at the time. Anyway, she called up and said, you really should apply for this. And I said, yes, Ruth, I will. I mean, for those of you who knew Ruth, when she asked you something, it was very hard to say anything other than, let me drop everything and do this right now. So I got my application in and eventually was offered the position. The plan originally was to move from north of Baltimore to Washington. We never did, so I spent the next 7.5 years commuting back and forth from Baltimore. It worked out great. I had a wonderful time at NIGMS, and I'll tell you a little bit about that. So in terms of, you'll hear probably a little bit more from Frances about women, perhaps in the intramural program. The extramural program, actually the representation of women is reasonably good. And in particular, when I was there, I recruited 4 or 5 senior people, and 3 of them were incredibly talented women. It was just sort of searching for best people, and it was a very, NIGMS is a very mixed gender environment. I think it's about balanced, and no one cares whether you're male or female. It's really a very comfortable environment. Certainly from my perspective, I never saw those sorts of issues come up at all. I also got a chance to work with Vivian Penn and Dr. Zerhouni on the Women in Biomedical Careers Working Group, which was something that came from Beyond Bias and Barriers. Donna Shalila called up Ilias and said, I don't expect this report to sit on your shelf. I want you to get to work on this. And he said, got it, and put together this group and was really very engaged. And Vivian was an incredibly effective leader. One of the projects I was most involved in was working with Renard Kington on a grant program for women in biomedical careers, which the grants were funded, and those things are moving forward fairly well. General extramural policy issues, some of which you heard about at NSF, were discussed quite a bit about, child care at meetings and some of the other issues you heard about in working with Barbara Alving, who was leading those efforts along with Wally Schaefer and Sally Rocky. So that was really a good group to be working with, and I believe it's continuing along as a standing group. It certainly had been when Dr. Collins took over. So back on the other side, Wendy had continued to thrive at Johns Hopkins Green Spring, which is the private practice. It's basically a private practice with a loose connection to Hopkins, specializing breast imaging. She really enjoyed the patient care there. It was a well-run practice in many ways, and as I said, did research on her own time as a consultant with Hopkins Green Spring as being one of the sites in the multi-center trials. Things seemed to be going along fine, and then May of a year and a half ago, she was called in and told that she wasn't a good fit, and given very short notice and sort of told it was time to move on. And this caught us very much off guard. I was very happy at NIH, and certainly Monica was 3 years away from finishing up high school, and we were certainly planning to stay put for the next few years. We needed to solve the problem again, and the way to do it was just to get all the options on the table. Pittsburgh had actually already been recruiting Wendy before all this happened. We looked extensively across the whole Washington, Baltimore area, various places around the country, trying to find a position where Wendy could do both research and patient care, particularly screening. When there was a situation that looked potentially interesting to Wendy, I found the person that I knew or knew somebody who knew and just sent them unsolicited emails saying, "You're recruiting my wife. This is going to go a lot better for both of us if there's something that I could do." In general, I got a lot of very confused responses to this. My new boss, Art Levine, wrote back very quickly and said, "Interesting, let me think about this for a minute," and got an email the next Monday saying, "You need to come visit Pittsburgh," and had conceived of a position to help him with science strategy and planning questions. And I came and visited, and it seemed like a good fit. It's really been, I'm just a few months in and sort of figuring it out. It was sort of a very long title and a blank piece of paper saying job description to be determined. And so we've been working on that. I also have a faculty appointment in computational and systems biology, and continuing to drift from, or as chemistry redefines itself, continuing to move in different directions. So when the decisions had been made, I was working on the press release for NIH about my departure, and wrote, "I'm leaving to support the career of my wife, who's been recruited at the University of Pittsburgh," and so on. And the folks at the Department of Health and Human Services says, "Why are you putting this in? This isn't relevant to your decision." And I said, "Yes, it is. This is why I'm doing this. It's very relevant to my decision. And people should know that this is something that happens." And it took multiple rounds and multiple tries of sort of pushing back, saying, "This is going to go out this way." And eventually they decided it was probably so trivial it didn't matter. So that's what the press release said. And then we posted, I had started a blog, the NIGMS Feedback Loop, and posted a slightly more extensive version of the same thing. Shortly thereafter, this had a much bigger impact than I ever imagined. So a female department chair said she overheard this conversation. It's bad enough that he's leaving because of his wife's career, but to publicly acknowledge it is a very bad precedent. So these issues are still just much more noteworthy than they should be. So I think we have a lot of work to do. Monica, who moved with us from Pittsburgh, actually she's 15. A sophomore in high school, was not thrilled about moving. My respect for her grew enormously. She was when it was still being negotiated, she was just the ultimate wet blanket. "I don't want to do this. This is a really bad idea." Grumpy. As soon as it became clear that we'd thought through everything and this really looked like the best solution for us and we were going to do it, she, over a period of about 5 minutes, shifted into negotiation mode. So it was like, okay, if this is happening, I get veto power over any house based on the kitchen. My room will be bigger than my current room, and so on. And she's been doing well. She also, sort of when I had, because of connections in the blogosphere, actually, I was privileged enough to get an award from the American Chemical Society, and there was a blog post from a chemist who runs this blog congratulating me, and I just wrote him an email thanking him for it. And I mentioned that my daughter, Monica, had accompanied me to the award ceremony on the Capitol, and he said this would be a great opportunity. So he actually interviewed. This is his scoop. So he did an interview with Monica about having two career parents and what's that like as a child, and it was very interesting to see her responses. The one thing which generated a lot of conversation, she said that her older brothers were an incredible help, that they always felt like a cohesive unit. She always could turn to them when she needed it, and people got into a big discussion of single kids versus multiple kids and so on. You can see she's always been very respectful of me. So just to finish, there still are, I think, subtle pressures to minimize the apparent impact of two careers and family considerations, both for men and women. I think women feel if they raise these issues, they're going to somehow be not looked on favorably. I think for men, it's always come very naturally for me, but the fact that people reacted to it always just sort of puzzled me, and I think there just aren't enough role models where this should seem as normal and natural as it really is. I feel sort of awkward getting all this attention for this when there are hundreds and thousands of other people who are solving these problems all the time. So let me stop there and then turn things over to Wendy.
So as you've already discerned, probably the most important thing and decision and advice I can give my daughter is marry very carefully. And if you have any doubts, don't do it. No, I think one of the best things about Jeremy is that he was not only interested in evolution scientifically, but personally and professionally. And I'm very pleased and very happy and very lucky to be married to him. Wanted to talk about this topic not only because this has been my life's work, and it's obviously why we ended up moving, as he told you, but because I think there are some interesting lessons in what's going on in the national debate right now. And in fact, this is now extended internationally. I've been involved in discussions in Austria. Canada just issued some very interesting guidelines, and I think it's worth talking about because it brings into focus a lot of the issues that affect us not only professionally, but also personally. The current recommendations for breast cancer screening from the American Cancer Society, which are also endorsed by my field and many other professional organizations, include annual mammography beginning at age 40 and continuing as long as the woman is in good health. They also include clinical breast examination every 3 years and then for women in their 20s and 30s and annually thereafter, and an optional breast self-examination. In November of 2009, the United States Preventive Services Task Force, however, recommended against routine screening mammography in women in their 40s and indicated that the decision to start regular biennial, in fact, not annual, but biennial screening mammography before age 50 should be an individual one and take patient context into account, including the patient's values regarding specific benefits and harms. And the intent of this, and this is from discussions with members of the task force, was for women to have an intelligent conversation of risks and benefits with their physician. This is ostensibly a very laudable goal. However, I think it was handled in a very awkward way from a message standpoint, And really the emphasis that they intended was on the word routine. They didn't want this to be a reflex action. They wanted more thoughtful discussion of the potential downsides to screening, including unnecessary biopsies and unnecessary testing. But in fact, this was taken largely by insurance companies and certain states that offer free screening mammograms to women who can't afford it as a message saying it's not worthwhile scientifically. And so this has created a lot of trouble for many of us, and albeit Kathleen Sebelius, of course, disavowed this, but nonetheless it's been a problem. And in fact, very recently, the Canadian task force looking at the same issue decided that in women in their 40s, they did not recommend any routine mammography at all, no clinical breast examination, and no self-examination. What does that leave us with? And even for women aged 50 to 74, mammograms every 2 to 3 years. This is really not a very helpful approach, obviously, because it means that we're going to wait until the breast cancer is much more advanced before it's going to be detected, and we do know the natural history of that. So I wanted to spend a little time talking about what is the science and how should women decide what to do, and how can we maybe influence this debate a little bit more, because it is an issue that requires a lot of discussion, including how do we decide when and what's the best way to implement new screening technologies. And maybe mammography really isn't the answer. I'm certainly not married to it. I do earn my career from it in some ways, but it's not a perfect technology. And how do we decide what to do? So the fundamental principle of screening is that early detection will alter the natural history of the disease. It should reduce the mortality if we detect it earlier. Otherwise, there's no point in screening. And that's sort of the discussion that goes on with prostate cancer right now. It's also important that earlier detection will allow breast conservation and less harmful treatments, less chemotherapy that's very toxic. That part of the discussion was not at all considered in the task force debate and discussion. And then a very important second issue is that healthy women, most women don't have breast cancer, should not be harmed by the screening. And for whatever reason, the task force decided to take to weight the harms much, much more than they had been in the past evaluations of screening. Finally, any test that we offer for screening should be widely available, cost-effective, and well-tolerated. There are many ways to evaluate the breasts at this time, and there are many more that are in the works. Clinical breast examination, self-exam, mammography, including new methods such as tomosynthesis and even injecting contrast like we do for MRI. Ultrasound, which I've spent a lot of time with, including looking at the stiffness of tissue by elastography. MRI, which does require contrast. And then finally molecular breast imaging and related technology using a glucose analog. There's also thermography, which I'm not going to discuss further except to say don't do it. It has no scientific basis. It does not detect early breast cancer. It should not be out there, and it is because it was grandfathered in long before the FDA oversaw this process. At this time, mammography is the only screening test which has been shown to reduce deaths due to breast cancer. And among women who actually participate in screening, we see a 40% reduction in mortality. We know the biggest risk is increasing age. The reason we start at 40 is because that's when we start to see a significant prevalence of disease. It does increase from there, but there's no absolute cutoff that says, at 50, suddenly we have a lot of it. We didn't have any before 50. It does increase more towards the latter half of the decade. So if you wanted to, Austria decided to start at 45. They have very similar curves. I think that's reasonable, but to say no screening arbitrarily based on age of 50 versus 40 is not very sensible. So what about reduction in mortality? Well, these issues, the strongest evidence we have is from randomized controlled trials. We have a group of women who are invited to screen. Actually, only about 70% of women who are invited to screen participate, so it's not perfect. You're not going to get the best measure of outcomes, even in randomized trials. Similarly, Group B is not invited to screen, but some of those women may choose to get screened outside of the invitation. And so, in any event, a randomized controlled trial underestimates the actual benefit of screening. And then the results are expressed as a relative risk of mortality in the group of women who were invited to screen versus the group that were not. A value of 1 indicates there's no reduction in deaths, and a value less than 1 indicates that there is a benefit to screening. Again, this does not look at any reduction in harmful treatments. We know that with mammography, we expect to find cancers generally that are smaller and therefore have a much longer survival after diagnosis compared to those that are detected clinically. And again, I just want to point out, it takes about 10 years, 7 to 10 years, to see some separation of the curves between mammography and clinical exam. And I'm not going to get into all the detail, but I just want to know that there is a lot of it. There have been 7, in fact 8 now randomized controlled trials of mammography, and overall there's at least a 20% benefit in terms of reduction in mortality. And the task force agreed with all of that analysis. They came to the same conclusion, and you can reach the same general conclusion among women in their 50s, where it's a 22% reduction or 0.78 relative risk of death, versus younger women, where it's about a 15% or reduction in deaths. And we also know it's been looked at how often one should be screened, and looking at data from Sweden, where we have much more extensive experience. It's particularly important to screen every year in women in their 40s because the cancers tend to be more aggressive biologically in that age group. The reduction in mortality is as high as 36% versus only 18% with biennial screening. And if you can only screen every 3 years, you really don't have any impact at all. It's much less of an issue to screen biennially in older women, so I don't disagree with the suggestion to decrease screening to every 2 years in older women. I think that's not ridiculous. As I mentioned, there is a delay in benefit to screening, so you really don't start to see separation of the curves until at least 7 to 10 years after you start. That's important to consider in older women. Should we consider screening after age 80? I mean, my mother, I had to argue with her about continuing to get a mammogram when she turned 90. I said, if you really want to, I'm not going to deny you that opportunity, but it's really not likely to help you because even the very healthiest women at age 90 are unlikely to live beyond about 7 years. And even if we detected the cancer earlier, you're just going to have years with breast cancer diagnosis again. She actually had it when I was in high school, which is how I got into this field. But it's not likely to actually change your outcome. So what about the harms? Well, there are many potential harms to any type of screening, and specifically with mammography, we have issues of overdiagnosis, which we'll talk about, false positives, false negatives, which are near and dear to my experience, and then radiation exposure. With overdiagnosis, this is probably the most debated and least scientific issue. Overdiagnosis would mean that the patient would be diagnosed with breast cancer, but it wouldn't have actually affected her life not to have been diagnosed. So it would be a clinically irrelevant disease that we've now treated her and in fact harmed her by treating her. She's now been exposed to surgery, radiation, potentially even chemotherapy for disease that would never have affected her during her lifetime. And this issue is very important with prostate cancer, and certainly some breast cancers are in this category. For example, low-grade DCIS that we diagnose in an 85-year-old, it's not something that we expect would actually have harmed her not to know about. Unfortunately, for most of the breast cancers in women in their 40s and 50s for that matter, there is sufficient horizon that even if it would take a while for it to turn into something more serious, that it most likely would. It's hard to study this because, of course, most cancers are treated. The only data that we really have to look at this concretely are where people have gone back to pathology specimens and said, oh, there was actually breast cancer there and it wasn't treated as such. What happened to the woman? But the vast majority of even the early breast cancer does become invasive if left alone. It just takes a different time threshold. The bottom line is, I think, a really solid analysis from studies in both Sweden and the UK looked at this, and for every 11 cancers diagnosed, it's estimated that 2 of those will be life-saving, 1 will be overdiagnosis, and the other 8 are going to need treatment either way. And often that last part gets sort of tossed aside as saying, well, then there's no point in screening. Well, that's not true, because no matter how you look at it, they're still detected earlier and more treatable with less harmful treatments in that, a lot of them are in that 8 So it's important to consider the full picture. False positives certainly exist, and this is where I think the opinion of women themselves needs to be considered and has not been very well. For every 1,000 women screened once in their 40s in this particular analysis, it's estimated that about 10% will be recalled that 1 year, so 100 of them. And 65 are going to have nothing of concern when we do additional testing, either ultrasound or additional mammographic views. 20 of them will require short-term follow-up, and 15 will need a biopsy. And of those 15 who need a biopsy, 2 to 5 will be found to have cancer. So there are many false positives compared to the cancer detection rate, and it really comes down to how harmful are those recalls, how much stress does it cause, how much pain and anxiety have we induced in the healthy women. Well, it's been asked, but not for a while. I think there is a need for a more current study of this and a broader study of this. One survey that's quoted a lot was from Schwartz back in 2000, which found that 63% of women felt that 500 or more false positives for one life saved was a reasonable trade-off. Well, going back to the previous slide, we said 2 to 5 women will be found to have cancer. So really, that's only about maybe half of a life saved for every 1,000 women screened on average, because not every cancer that we find have we saved the life. So it's in the ballpark, but it's around that number. In terms of just attitudes towards recall and biopsy, this was actually from the University of Pittsburgh before I got there. 86% of women presenting for mammography were willing to be recalled if it increased the chances of detecting cancer earlier, 82% willing to have a biopsy if it increased chances of earlier detection. What about false negatives? Well, the dominant issue in us not seeing cancer on a mammogram is breast density, and this is another hot topic politically right now. The risk of false negatives increases with increasing breast density. We have 92% or so sensitivity to cancer in fatty breasts, but less than half of cancers present in dense breasts are going to be seen mammographically. And that's just because they can be hidden by the whiter breast tissue that's considered dense. The white cancer just doesn't show up against this background. One of the other unfortunate things to this is that it's actually a risk factor for developing breast cancer as well. So women who have very dense breast tissue have at least a 3 to 6-fold increased risk of developing breast cancer compared to women with fatty breasts. So it's a double whammy. We have an increased risk that's quite significant. We really don't hear about 5-fold increased risk. We hear about 10% increased risk with various things in medicine in general. It's a very strong risk factor. And it decreases the chance of finding that cancer when the tissue is dense. We know that from a clinical standpoint, most of the cancers that end up being more advanced at detection are the ones that present with a lump in the interval between screening. So the woman had a negative mammogram, and then 6 months later feels a lump, and that turns out to be cancer. Those tend to be more aggressive and with worse prognosis. And women with very dense breasts are 17 times more likely to have an interval breast cancer than women with fatty breasts. We also know that breast density decreases with age. As we get older, it's less likely to have dense breast tissue, but it's still common. Even among women who are in their 60s and 70s, it's about 20% of women who have somewhat dense breast tissue. It's worse with young women, which is part of the reason that we see reduced performance of mammography and a reduced impact from mammography. And as I mentioned, cancers do tend to be more biologically aggressive. The women who are still dying from breast cancer, the majority have not had a mammogram at all, so we still have issues with access and participation and screening. And that's actually getting a lot worse now with all this debate. About 40% of women who do die, though, have had some screening, and some of those are just really bad tumors that grow quickly, that it didn't, we saw it, but it still misbehaved. Some of them, though, and the most of them really, are in this category of either missed on the mammogram, not detectable because of the dense tissue, or very high-grade cancer, or both, that came up between screens. So a big issue at the national level right now is, should we be telling women how dense their breasts are? We know it from the mammogram. It's part of our routine report. We always have said it for at least the last 15 years since I've been in the field. It's part of our standard first line of our mammography report. The referring physician gets that information, but historically it's not information that's been included in the letter that is required to be sent to the patient with the results of the breast exam, their mammography. So there are several organizations that are trying to change this that have all been inspired by individual women who've had bad experience of having dense breasts, being diagnosed with cancer, and not knowing that part of the reason that they had a relatively advanced cancer was because their tissue was dense. So in Connecticut, in 2009, prompted by Nancy Capello, who's one such individual, there was a law passed that required the mammography report to include this information. And actually before that, there had been a separate law that required insurance to provide coverage for the mammogram beginning at age 40 every year, and also to include coverage for ultrasound screening if the breasts were dense, and also could include even MRI, although that's probably more than is necessary. Currently, there's a discussion of similar legislation in many other states. Illinois has the insurance payment, but no requirement to inform the women of their breast density. Texas has the inform component, but no insurance payment. New York is discussing both still. California, the information was vetoed by Governor Brown. I actually have radiology colleagues in Pennsylvania who felt we should recruit Jerry Brown to Pennsylvania because many radiologists are opposed to this, and I'll talk more about that. And Pennsylvania is among the states that has introduced similar legislation this session. There's also the National FDA Mammography Quality Assurance Committee that had a hearing in early November to discuss this issue. I think it was agreed that it would be reasonable to require this be in our reports. Right now it's just standardly done, but to require it, that was pretty agreeable to everybody. But there was a lot less agreement about whether or not to include it in the lay letter to patients, and we won't know probably for several years what their decision will be as that works its way through channels. So why is this something that's opposed by my community? Well, that's a question I've been struggling with, and I've actually been on the wrong side of this issue from their perspective. It's opposed because it's imprecise. Well, we can disagree. One radiologist might call the breasts heterogeneously dense, and another one might say there's only minimal scattered fibroglandular density. Okay, well, one radiologist might actually see the cancer and one might not. One radiologist might recommend a 6-month follow-up and one might not. Our level of agreement is actually the same for stating the breast density as it is for the final assessment that we give to that mammogram. It's no worse, no better than anything else we do. Okay, it's not perfect, but that doesn't mean it's not still a very strong risk factor. Well, then it also would undermine the confidence of women in mammography if they get a different answer one year to the next. Well, I think really what they're saying is it may undermine the confidence in mammography if women know that the mammogram could miss their cancer. And I think that's really part of this problem in a big way. Another statement, no science. Well, we'll talk about that. What about it would cause anxiety among the women who know they have dense breasts? And gee, that's a harm to all those women because what can they do about it? Well, that's not completely unreasonable, although there are studies that you can reduce your breast density with tamoxifen, and obviously these are issues that merit study. So maybe if we knew and were pushing for more science on some of these issues about what to do about it, we could have some more solutions to it. Finally, women with fatty breasts would become complacent and not want to worry about their breasts anymore. These are sort of crazy statements, but they're being made. And then finally, I think it's a real issue, though, that if we don't have insurance payment for any kind of supplemental testing, if we're going to say the breasts are dense, so we actually could do something about it, potentially by doing an ultrasound, I'll talk more about that, then in theory, at least, we should offer that option to women. And if we're going to require that the woman pay for it herself out of pocket, we do have issues of access that do become problematic from a policy standpoint. Well, here's just a summary of the literature showing that there is an association of breast density and cancer risk. So the statement that there's no science, there's 17 different studies from, I think it's 8 different countries that have shown this to be a risk factor. And you can see the odds ratios range from as low as, 1.8 for one study, but basically they're in the sort of 4 to 6 fold increased risk across all these studies. So again, we're not talking about a tiny risk. We're talking about a very large risk, but it's been largely kept a secret. So I think what I have come to is that it's really opposed, because to provide this information then is to recognize the biggest limitation of mammography. And for years, we've kind of oversold mammography, saying that, gee, get your mammogram, it'll save your life. And obviously that's not the case, unfortunately. It might be the case for some, but it's not going to be the case for all. And in fact, for most, it will help us find it earlier, perhaps, but it's not going to save the life for most of the women getting it. I think it also comes from individuals who've spent years of their lives fighting the battle to defend mammography, and this continues to be an issue, so they're very sensitive to this. And then obviously the other issue is that there's a lot of equipment and process already in place to do mammography. There is a tremendous need for training, expertise, to some extent equipment, if we're going to add something to that, be it ultrasound or MRI, or tomosynthesis or other things that we can talk about. So it's a problem from a practical standpoint to implement something new. So let's talk for the last few minutes about some of these new approaches. And I think really the question, we know the natural history of breast cancer, and we know that at least in principle, if we have another method that can find node-negative invasive breast cancers, that should improve the outcomes. It should reduce the mortality due to breast cancer. It should have a beneficial impact on women. The real question is, do we need randomized trials of each new technology, looking at differences in mortality? If we do, if from a policy standpoint we say we do, that means we're looking at least 10 and probably 20 years before these technologies would be implemented. And I would argue that that's absurd at this point, given what we know about the natural history of the disease. But these are issues that there is no national agreement at the policy level on these issues. So we're going to talk about finding cancers that are invasive, less than a centimeter, node negative, and with a low interval cancer rate, less than 10%. Well, what about this? Clinical breast exam, actually, there is no randomized data on this, randomized controlled data, despite the fact that it's been offered for many, many years. And the overall benefit to it is about a 2 to 6% increase in cancer detection compared to mammography alone, so minuscule. And this is one of the reasons why Canada has not recommended it and why the task force gave it a very lukewarm, very weak recommendation to consider it. It really doesn't have any proof of benefit to speak of. Breast self-exam is a controversial issue, but the bottom line is that when you teach self-exam, there have been 2 studies prospectively doing this in Russia and in China, where it showed maybe slight increase in cancer detection, but nearly twice as many benign biopsies in the women who were taught self-exam, and no difference in survival. So from a scientific standpoint, it's unsupportable. But from a practical standpoint, the American Cancer Society, I think, has the right idea that self-awareness is quite important. And certainly, once you feel a lump, if you feel a lump, you should seek medical attention as soon as possible, not delay it. But it is not something that we can prove it to be of benefit if we teach it. What about tomosynthesis? Well, it's one of the new technologies that can functionally does the equivalent of a mammogram, but slices. So we see through some of that dense tissue if there's fatty tissue mixed in. It does currently, because we're required to give a standard mammogram as well as a tomosynthesis, it's more radiation than a standard mammogram because we have to do it in addition to. And here's just an example, and hopefully this will play. Yep. So with tomosynthesis, we get all these slices to look through, and it allows us to see what we really couldn't see very well on the original mammogram. And in this light, you probably can't see it either, but nonetheless, we get the distortion around it, and it does allow us to see cancers better. And here's, I think, a nice example. These are from Mass General, where they've been doing a lot of this work, and we're doing it at Pittsburgh. So that's one option. MRI is another option that is being recommended for women at high risk, and there are lots of different factors, but mainly if we suspect that they may be a carrier of a BRCA mutation or know them to be, and that would include women who have a very high lifetime risk of breast cancer by one of these models. In practice, this is great, except that we collect all the information we would need to decide all this, but we don't have any way to implement this in practice. So breast centers, we ask family history, ovarian cancer family history, many issues, age of diagnosis, but we don't sit down and put all this into models and say, oh, you're someone who should get an MRI. We don't even really ideally recommend that you see a genetic counselor. We're getting this information, but we're overloaded with information without being able to use it. So this is where we kind of need something like Watson operating in the background. Collect this information, spit out to us her risk by 4 or 5 different models, and say this is somebody who needs the brochure for the high-risk clinic. It's not being done. It hasn't been done, even though these guidelines came out in 2007. Here's just an example of a patient who had very dense breasts, but cancer was seen very nicely on the MRI. It's a very sensitive test. Here's another example. Dense mammogram, nothing on the mammogram. All this is cancer. Okay. Well, and we know from the literature, it's, as I said, very sensitive, 81% by itself, and even better, 93% if you add it to mammography alone. And the numbers for mammography alone in these same studies were on the order of 37%. We also know that if we do the MRI, we don't need to do ultrasound because it just doesn't add anything above and beyond the MRI. But not everybody wants to have an MRI. It's a very expensive test, and it requires injecting contrast. It requires going in a tunnel. There's claustrophobia issues. So we studied this actually within the Akron trial. 42% of women who were eligible declined a free MRI. There's also a large group of women, so those women at high risk who would merit an MRI, they need some alternative. And there's also a large group of women who are intermediate risk for breast cancer, who, for example, have an intermediate family history or have a high-risk lesion. Dense breasts are among these women in this group, and women with a personal history of breast cancer. And so there's really no clear recommendation what to do in these women, and this is where I think ultrasound has a role. So there have been many single-center studies before the Akron trial. We find basically about 3.5 cancers per 1,000 women screened, which is quite similar to the initial yield of the mammogram. So essentially nearly doubled the cancer detection rate in these early studies. There was a study from Italy that was multi-center published after we started the Akron trial. Again, almost double the rate of cancer detection. And are they the right types of cancers? Yes. Their average size is 12 millimeter, 82% were node negative. So they're mostly invasive cancers that are node negative, which is exactly what we wanted to find. What about in the Akron trial? This is unpublished information, so hope this isn't going out on the website yet. But the bottom line is that we had a 29% absolute increase in cancer detection, adding physician-performed ultrasound to the mammogram, and 94% were invasive, and they were mostly, again, node negative with an median size of 10 millimeter. So the right types of cancers. Here's a fatty breast, easy to see cancer, dense breast, woman in the trial. Here's the cancer that was seen only on ultrasound. It's relatively small. Not like a bright light bulb like MRI. So this is one of the reasons that the radiologists don't love this, is it's harder. It's not quite as easy to interpret. It's not quite as easy to perform. Somebody has to do the scanning mostly by hand or with the automated device where we end up with lots of images to look at. Here's another patient with it. And again, cancer only on ultrasound. So one of the things that I mentioned was the interval cancer rate, which has to be low. And these are clinically detected. The interval between screens, only 8%. Across the trial. So even though MRI is even more sensitive than ultrasound, we found the combination of mammography and ultrasound alone to be quite effective in preventing late-stage disease in this trial. What about the downsides? Well, there is an increase in unnecessary biopsies and unnecessary short-term follow-ups, and basically 7 to 8% of women end up with an extra test, recall, short-term follow-up, what have you, because of adding the ultrasound. So 7 or 8 women in 100 each time we did the ultrasound, and it was effective each year. We found another issue that's criticized for was that among the women who were biopsied, only 10% of those biopsies showed cancer. So that's a lot of unnecessary biopsies. On the other hand, it's a very simple procedure that takes about 15 minutes in the office. It doesn't require any compression. There's no radiation. It's very much like going to the dentist, but a very short dental visit. having spent a lot of time in the dental chair. And it really, most women find this quite tolerable. And in fact, we have tolerability and cost-effectiveness analysis as part of the trial, very well tolerated and equally cost-effective to mammography. And in fact, you could even make the case that it's more effective than doing mammogram. Well, as I said, one of the questions at this point is how are policies made and how are we going to get some of these new technologies that might be beneficial into the hands of women? And that's really the question. We know that nobody with expertise in breast cancer was on the task force, and that was a criticism that I think is valid. We also know that that task force guideline did change practice. There was a survey on the Annals of Internal Medicine website shortly after the guidelines were released. Among healthcare providers, 67% said they were going to stop offering mammograms to women in their 40s. Again, that wasn't the intent of the task force, but that was the effect. 62% were going to advise every 2-year mammograms. Again, I don't disagree with that in women, older women. Another half of them were going to stop screening women over age 75. Well, actually, a recent study from MD Anderson says that we should really work more aggressively in screening older women because you might have remembered from the incidence curves that the incidence gets higher the older we get. And in fact, we're going to be more effective finding cancer, and we've probably been under-treating women over age 75. So there's a lack of randomized trial evidence over 75, but that doesn't mean it's not effective. So how are we going to approach that issue? And the others, we've talked about breast self-exam and clinical exam. Well, what about women? What do we want? Are they going to ask us? Do they care? Good question. Well, so among women who responded to this survey, 71% said they were not going to pay attention to what their physician said. They were going to still get screening mammograms. And in fact, another more than 80% were not going to forego breast self-exam or mammography. And I think I already mentioned this. And the bottom line is that there's also a survey from the Are You Dense advocacy group that they did 1,000 women, representative of the population of the United States in August. Does waiting for mammogram results cause anxiety? Yeah, about half of patients said yes. Does that cause you to miss a scheduled mammogram? Are you so incapacitated that you wouldn't do it anymore? The vast majority said no, of course not. What about this dense breast issue? Well, they explained it so that if you have dense breasts, that you'd be 3 to 5 times more likely to develop breast cancer. Mammograms are unable to detect at least 40% of cancers in dense breast tissue. It's actually probably higher than that. Ultrasound and MRI can find cancers in those breasts without radiation. So if you were told you had dense breasts in addition to mammography, would you want ultrasound or MRI if it increased the likelihood of finding a breast cancer? 93% said yes. If insurance did not cover the additional screening, how much would you be willing to pay out of pocket? 78% said up to $250, and in fact, 24% overall said up to $500. So they were allowed to choose more than one. It'd be nice if it would be covered. The average insurance reimbursement is actually $100 where it's paid. That's really why we don't want to offer it as a field, because we don't make money doing it. The harms of false positives, okay, if a suspicious area was found and you had to have it biopsied and it wasn't cancer, would that prevent you from having that test? Would you elect to have it next year? Yeah, okay. We can tolerate a false positive. We understand the issues. We are intelligent people. So overall, if we look at all the possible tests that we can add to mammograms, 3% benefit from clinical breast exam. Double reading and CAD may be similar, sort of 3 to 7%. Tomosynthesis, hard to get your numbers because nothing has been published after many, many years of study, but there is some benefit. Ballpark best number I could get is about 11% increase. Ultrasound, we know from our trial, 29% increase in cancer detection. MRI and, in fact, molecular breast imaging, probably even much more, but both requiring contrast injection or tracer radiation injection in the latter, and they're very expensive tests. So I think on average, if you look at the balance of factors and the low interval cancer rate in our trial and the lack of radiation, the ultrasound looks pretty good. So in conclusion, mammography is effective, but women are still dying of breast cancer. Several methods improve this cancer detection, but really the question is, do we need proof of mortality reduction, and who's going to make that decision? What women want is information, I think. It's been pretty consistent in my practice. And I think we are capable of making intelligent decisions. Furthermore, referring physicians really don't have the time to carefully explain all these issues or master all this. It's taken me a lifetime in this field to really understand all the issues involved with screening and every other possible test. So what's left to us as patients is speak up, ask questions, and insist on progress. Thank you. And we're open to questions, but I know there's a break, so if people want to talk to us informally, that's fine too. Yeah.
I have a couple of questions and observations. I was wondering if there's, you mentioned race and ethnicity superficially. Has there been any correlation between the dense breast and racial ethnicity, race and ethnicity?
Certainly. So the question, it's really about density and ethnicity and racial. To some extent, Asian women tend to have denser breasts, and to some extent, women who are large-breasted tend to be more fatty. So it's self-correcting in the sense of ultrasound, which doesn't penetrate very deeply into the tissue. The good news is that we wouldn't recommend ultrasound in women who have fatty breasts, and there tend to be the large breasts that ultrasound wouldn't do very well with. Ultrasound is actually very widely used in Asia because most women have small, dense breasts. Again, there are always exceptions, and these are generalities. But yeah, I mean, that's sort of, and in Europe it's also much more widely used, but similar distribution of density. But
a couple of other questions. Is there any incremental risk with in patients with dense breast that have a family history that is non-BCRA positive? That's one. And the other is, you said that the increased probability of detecting breast cancer by adding the ultrasound was physician. So, let me answer the latter question first. So most of the studies that have looked at supplemental screening with ultrasound have been done by a physician, but not all. And I was actually told to not look at our outcomes at Greenspring, where we had taught our technologists to do it, but I can tell you that they were equal, in fact better than our physicians, because I think their attention span is longer, they're less distracted, less interrupted, and more able to do a consistent job. That's good.
And worldwide, I mean, Japan is actually in the middle of a randomized trial of 50,000 women in each arm, 50,000 women getting ultrasound in addition to mammography and 50,000 not. And the technologists are trained as part of a 3-day workshop along with their physicians, but the technologists are doing the screening. Again, very similar outcomes. So there's really nothing to say that you can't do it.
So it's not impractical.
It's not. What it is a requirement of training that we haven't had the national willpower to do, and that my breast imaging colleagues have great resistance to doing, largely because the reimbursement is low, and there's no driving force to do it. From that standpoint, they're overburdened and they don't want to do it. In fact, I've heard the statement made by the head of the Society of Breast Imaging, "I don't want to talk about it." That's where this is right now. From the first question, I think, was the interaction of family history and breast density. And I'm not sure that I know the answer to that. It might be in some of those papers that they've looked at that, but both are very common. Family history, we expect in about 15% of our population. It is probably somewhat additive, but I don't know the exact how much additive to breast density, which is about a third of our overall population. So.
Thank you. I want to thank both of you for your comments. And I have a question that I'm going to pose to both of you, and it goes back to the issue of work-life balance that you two seem to be, the poster children for figuring out how to do this. I've spent 15 years listening mostly to my junior women faculty complain and really bemoan the fact that they feel overwhelmed, particularly when they start to have children. These tend to be closed-door conversations. The box of tissues often comes out, and I just see the incredible sense of frustration on the part of these women. And I've done a lot of listening, and I'm not sure I had any real insights until one of my faculty members made a comment about 6 months ago that really caused me to think about things in a different way. And her comment was, and she's two-career couple. Her husband is not in science, but I'm not sure that this really matters. But what she said was that she really had the sense that he didn't feel that it was acceptable for him to want to be as involved with children and as nurturing as she is. And so it really got me to thinking, have we as a society sent the wrong message to men? And if we can find ways to encourage men to be as involved as women, do we not only solve a problem for men that maybe they are secretly longing to be more involved with family, but in doing that, have we made the situation better for everyone? And so I guess in part, Jeremy, I guess I would just ask you, have you ever felt personally, or have you ever had a sense in dealing with your male colleagues that they might want to be more involved with family, but the pressure from society really moves them in a different direction? And Wendy, your comments as well would be equally appreciated.
So let me start with, in terms of the solution to the problem, I think one key thing is wherever possible, be as interchangeable as possible. I mean, you have to be able to juggle, and if somebody needs to cook, if only one person can cook, you're in trouble and things like that.
That's obvious to both
Right.
of you. I'm not sure it's as obvious.
Right, but I mean, I
to
think
everyone
in
else.
terms of what's worked for us, I think we've been.
What are the lessons learned? Yeah.
We've tried to be as interchangeable. Living with your mother-in-law, living with your mother, not necessarily optimal, but it was, in the grand scheme of things, our kids turned out well, and it was the right thing. In terms of men, I guess there are a couple of things. One, men are not completely monolithic, but there's actually a range of views. I think, but in college somebody asked me, if you were a guy, would you like this shirt? It was like, I don't know, I have to hypothesize. But I think there is a sense that for men that being involved is viewed by other men as being a sign of weakness or something else. I've also been incredibly lucky to be, because my career took off so fast, I could say, I really hope this meeting at 6:30 goes really well. Take good notes, because I'm not going to be there. And I didn't have to worry about not getting tenure and all those sorts of things. And I think those sorts of pressures hit everybody. I mean, that happened at Hopkins when I was there. The Department of Medicine did a study on why they weren't mentoring their women faculty very well, and they concluded they weren't mentoring any of their faculty very well. And there were a lot of these issues that no one was thinking about, work-life balance sorts of issues. I think men, if you could figure out how to do it, would, in general, there would be a substantial fraction of men who would like the license to be more involved and not have to say, I've got to make up some completely lame excuse for the fact that they're actually going to a ballet recital or something like that, that they're working on a paper that they have to review or something. And, I know that sort of stuff goes on. But it's, and then on the other hand, there also are men who, I think men have gotten an incredibly good deal all along the way, and they're perfectly willing to make incredible, it's great the kids are turning out so well, I'm delighted to be involved, and next time you need me, just let me know. Hopefully it won't be too soon. Sorry.
No, I mean, I think all those are valid comments. One of the things that Hopkins did do during the time we were there was to change so that they stopped having regular meetings after 5 o'clock. And that's a real fundamental family-friendly thing to do. It's interesting, in Pittsburgh, they actually have a lot of things at 7 and at 5, and they're not sensitive to that at all, and yet they're much more aware of recruiting to career and there are a lot of things they've done like that. So there is a tone deafness out there, and I do think, one of the things I heard on NPR actually last week was that with the economic situation the way it is, a lot of men losing their jobs, they are turning to be the primary caregiver for their kids. And so for whatever, variety of reasons, this situation is changing, which may help things in the long run. I think there's nothing like walking in someone else's shoes to understand how much of a juggle and how hard it is. It is definitely the Malcolm Gladwell, you've got to be willing to put in the 10,000 hours, and something's got to give, which means that both people have got to give to make that work. It has to be a team. And, with regard to mentoring, I will just add the comment that in my own career, not only did I not have a mentor once I got into the clinical departments, I had what I would call sort of the most destructive possible chairs and mentors. And at some level, I think to succeed, you have to have a tremendous ego that you might be able to make a difference. And that's one question I think is important to ask of a female faculty person relatively early on. Do you care enough to make those sacrifices? And as was pointed out earlier, sometimes work has to come first. Are you willing to do that and be in that situation? But one of the good sides, and I think this has affected Jeremy a lot too, is that having that tremendous time pressure, if you will, of every minute has to count, is actually a good thing, because it makes you more selective about how you spend your time. And when you have time with family, you make it good time, quality time. We didn't always have dinner together at all, but we always had time for the kids and their work. And even now, I proofread my son's papers for his college finals, and we do it. We've always been involved. We always cared. And similarly, what we worked on in our extracurricular time, our research time, whatever you want to call it, had to matter, because we knew it had a lot of effects on everybody else who we cared about. And I think that's actually a good thing. Many men who spend their entire 24 hours a day in the lab, basically. That doesn't necessarily lead to the best science.
Yeah, sort of taking things back to Rosalind Franklin, I think the one things that the British have done very well is, because they've been underfunded historically, is they spend a lot of time planning experiments and not that much time doing them. Yeah. Whereas opposed to the U.S. model of you sort of generate the data and then you move on to the next experiment. I think so. One thing of having, as Wendy said, of having this, taking the time commitment seriously for family time is you think, and you say, what does this mean? And you just have 8 hours to focus on something other than the experiment, and that pays off. That certainly paid off for me many times in my, if you look at the genesis of where a lot of the most important advances in my career have been, it comes from the thought that occurred while, changing a diaper or waiting for Wendy to finish up in the lab or whatever.
Well, and one of the best talks I think I ever heard was Don Coffey at Hopkins, who made the comment, people spend 90% of their time creating data and only 10% of their time thinking about the results. And it's true. A lot of people are in such a hurry, and I currently review abstracts for our major radiology meeting. I can't even tell you how much of the work is sort of I decided to do another retrospective analysis of X, Y, or Z, instead of thinking about something, prospectively planning it, committing to a 5-year plan to do an actual research study that matters, as opposed to feeling the pressure to generate some short-term project for a resident or fellow that might add to my CV so I have a list of stuff that doesn't mean anything. That's, I think, there is this problem that's kind of fostered and encouraged by the system without anybody having the guts to step back and say, what, I'm going to do something that matters. And then, obviously, those are the ones that might have an impact, but it's complicated.
I think, first of all, it's just wonderful to hear the two of you, and to a certain degree reflect the kind of careers my husband and I have had. And I think that's great that you can compare. One, you went smooth as could be into essentially a career where you had support and you had to struggle all the way, and yet you've been learning from each other, and that's just superb.
I had one very good mentor.
I know. And he has a mentor, too, because he sees what's been done to you. So I just think it's spectacular. But what you had, Jeremy, is something that I think all of our junior people need to have, that rapid period where you're not, as you said, you could take the kid to the lab on your back and nobody said anything. And so can you, especially from your NIH vantage point, can you see a way of providing support for junior people so that they have a prolonged period where they don't have to turn out a grant every 3 years or to go for that competitive renewal when the baby's just been born?
So I'm gonna one of my favorite Elias Zerhouni quotes is, people ask him what keeps him up at night, and the reality is he sleeps like a baby. He wakes up every 3 hours screaming. I think academia, and certainly academic medicine, and has gotten itself into a direction, well, but it's broader than academic medicine, in a direction that's really terrifying. And, I think people are running faster and faster to stay in the same place. People's careers are very slow. People feel incredible pressure. I interviewed a job candidate for a wonderful position at Pittsburgh yesterday. He was a very well-funded sort of superstar rising guy. And he said that his response to the current NIH funding situation is going to be writing a grant every month. And it was like, and you will accomplish what? It's a perfectly reasonable, rational response to the situation, but it's crazy. So, I think there's a lot of culture change that has to. That's the one thing I learned. Probably the biggest lesson I learned in 7.5 years at NIH is I should have become a sociologist. All this is about cultures and people, and that we send all these messages to each other, intentionally or otherwise, that we pick up, and that's what humans evolved to do. And messages about what's okay and what's not okay are pretty strong. And until we get more role models and more people who are willing to sort of push back against the strong forces of insanity that are going forward, I think we're going to really have a struggle. I think what's happening with promotion decisions more in Europe than in here, but not to pick on publishers, but the impact factor, formula-based promotion, that you have X papers and they have published in different journals with this impact factor, and at the end of the day, you can come to a conclusion of whether they should be promoted or not without anybody having read the paper and said, does this make any difference in the world, is crazy. And young people is certainly one thing. Early career people, I think NIH is paying some attention to, but it's gotten so out of equilibrium at this point that it's, trying to get the average age of an R01 down from 42 is not where you want to be starting. I think if we went around the country and really explained to young people what a career in academia was like at this time, we would have the success rate of NIH grants would go up a lot because no one would go into science.
On that cheery note, let's take a 10-minute to 9-minute break and come back at 4:30.
They gave it back to you, isn't it?